Assalamualaikum warahmatullahi wabarakatuh, and hi everyone. Can you hear me? Okay, so since now it's already 8:20 p.m., I don't think that we can wait any longer. First of all, I would like to thank all of you because today is it's a weekend and Saturday some more and at night time, but still spend your time to join us for the sharing. So today we are going to have a sharing by Mr. Muhammad Fahrizuan. He is a medical physicist at Diagnostic Imaging for KPJ Johor Specialist Hospital. So he actually will give us a sharing about the PET CT scan in Malaysia, and there are like few outlines that he's going to go through. Fahrizuan, are you ready?
Hello. Yes, doctor.
Okay. So basically we are going to have a sharing first. Are you okay if there is a participant who want to interrupt in between when you give your share during the sharing, or you prefer them to keep the question at the end?
I think I prefer they keep the question at the end.
Okay, all right.
Yeah.
So if you have any question later on, so after the presentation by Mr. Fahrizuan, you can just unmute yourself, or you can just type in the question in the chat box. So if you just want to state any number, so you can just send a personal question to me, so I will read on your behalf. So without further ado, I would like to call upon Mr. Muhammad Fahrizuan. You can start now. You can maybe
Okay.
start sharing your slides,
Okay, sure.
and you can just start when you're ready.
Okay. Okay, can you see my screen?
Yes.
Okay. First of all, Assalamualaikum and a very good night, everyone. First of all, I would like to thank to Dr. Sakina for giving me a chance to do this sharing session. Uh, So our topic today is entitled PET scan in Malaysia. Before we start, I would like to introduce myself. My name is Muhammad Fahrizuan bin Muhammad Yusuf. I'm currently working in KPJ Johor Specialist Hospital. I'm working as a medical physicist for 2 years. Before this, I'm working in Gleneagles Hospital in radiotherapy department. So today topic is divided into three subtopic. Our topic for today is PET scan in Malaysia. The first one I will share to you the clinical flow in PET scan and also the difference between gallium-68, which is a technique to produce the medication for the PET scan. Because we have two method, which is usually we use FDG F18, which uses to detect the cancer as a general. But in the new one, which is gallium-68, to produce, to see and diagnose the specific cancer, which is neuroendocrine tumor and also a prostate cancer. And then I will share you a bit about the quality assurance in PET scan. So why I choose this topic actually because in Malaysia, actually oncologists have difficulties in detecting the early stage of a cancer patient. Usually, they only know the patient at the late stage, which is in palliative, which usually they only give the chances to live is very low. So in Malaysia, actually, PET scan is now already have a 16 center in Malaysia, mainly in Klang Valley, and southern region is in Johor. Still no PET scan in Sabah and Sarawak, especially in Borneo. Actually, they have one, but they use a small cyclotron, which is can produce only for 3 patients per day. Like in Semenanjung, they can produce more than 10 patients per day. Okay, so I think this topic is interesting. That's why I choose this topic to share with you. So now let's move to the first slide, overview of my presentation. Firstly, I will introduce to you about the nuclear medicine services in Malaysia and also the role of medical physicists in nuclear medicine, and then clinical flow in PET scan, as well as the production of FDG, gallium-68, cyclotron, and GS68 generator. This one later I will talk about this, and also I will give a brief about the neuroendocrine tumor and also prostate cancer. Next, we will see the difference in images between FDG and also gallium-68 medication. I call this as a medication because the radioactive is produced in usually in Malaysia. We have a few center. For private center, they usually produce in Beacon and also IBA. There is two factory which produce this medication for PET scan. And for government, they produce in-house, which is in IKN. They have their own cyclotron to produce FDG. Okay, and then I will share about the national cancer statistic and also conclusion. So let's move to the first slide. Nuclear medicine services. Okay, in hospital, usually we have 3 medical specialties that use radiation science to help in combating ionizing radiation source. So usually we know in X-ray department, they use the X-ray to image the patient body, right? But actually we have radiotherapy and also nuclear medicine. This one is rarely been exposed to public because it's usually few center that have these modalities. So in diagnostic imaging, usually we use a conventional radiology, and for cancer therapy, we usually in a radiotherapy department. And for diagnosis, I will focus on nuclear medicine. Okay, then these three medical specialties have been identified and defined under Atomic Energy Licensing Act. So let's move to the next slide. Okay, so role of medical physicists, I will explain to you a little bit. So usually what I'm doing is I'm working as a radiation protection officer and also receiving radioactive material. This one is FDG that we order. Usually I will receive and I will prepare for the, I will give to the pharmacist so the pharmacist can prepare the medication soon. And then I have to monitor the radioactive material packaging. So when there is a leakage or anything problem with the packaging, I will have to report to the KKM, and also I have to send back to the consignor. Okay, and then I have to do the safe management and disposal of hazardous material and medical waste. So another thing is I have to monitor and supervise and control area to ensure level radiation within acceptable limit. This one, I will monitor each of the room inside the PET scan. So to ensure the radiation is in a normal level. And then if there is abnormality exposure to relevant authority, I will notify them. And then I involve in a planning new facility. And lastly, the most important thing is I will do the QC for the machine. Usually I will do a daily, weekly, and also quarterly. And then this one is training program. Usually in government sector, they will do. As well as lastly, in research and development nuclear medicine center. So next. So actually, what is PET scan? We only hear PET scan, right? But what actually this? This is a scan which is same with CT scan, but CT scan, they don't give a functional characteristic of the cells. In PET scan, they can actually trace which the location of the cancer. CT scan, they only can see the tissues of the patient. They cannot see and detect exactly where is the location of the cancer. So PET scan is medical imaging technique which is made using positron emission tomography, which is PET. This one PET. That's why it's called as PET scan. To provide detailed picture what is happening inside our body at molecular and cellular level, and also it gives functional image for the specific disease and cancer location, so physician easy to assess soon. This PET scan require a radiopharmaceutical. Radiopharmaceutical is the FDG, as I mentioned before. It will bring the radionuclide to the disease location. So the medication will bring the FDG to the patient body, where is the location of the cancer, and then the image will be translated. In this picture, this is the radiopharmaceutical, and then the medication will move to the specific location of the patient which has a cancer. Okay, next I will show you the clinical flow in PET scan. Okay, firstly, the medication which is used for PET scan will be sent to hospital. So physicists will receive the FDG. Usually FDG which is produced from BioM and also Beacon Specialist Hospital. And then I will receive this medication. After that, the radiopharmacist will dispense the medication, which means they will take the medication and also prepare for the patient for the injection. After the medication prepare, the radiographer or or the technician will inject the patient at the waiting room or at the specialized room for the patient. And also patient have to wait for 40 minutes. After patient wait for 40 minutes, they will do the scan. Radiographer will do the scan. So in this case, patient which is injected with this radioactive material will be highly radioactive. So we need to have a specialized room for the patient. Specialized room, we have two. Each of these specialized room have a proper shielding, which is enough to attenuate the rays coming from the patient. So it is safe for the staff. And then after the patient finish scan, the image will be transferred and also combined, which is CT scan combined with PET scan. So this is the PET scan machine. Maybe you never heard about PET scan, so I show you the image. This is from our hospital. It is same as CT scan, not have much difference with CT scan, but this PET scan, they have a detector array along this hollow tube. So there will be a detector around this tube, around this region to detect the PET, to detect the photons which is produced by the an inhalation process. Next, I will show you what is happening inside PET scan. So as you can see this picture, this is the patient. It will move inside the scanner. I show you this picture. Sorry. Okay, this one is the PET scan. So patient will move inside this scanner, and then there is a reaction inside the patient body after we inject the patient with the FDG. So there will be an inhalation process, which is the positron, the positron is produced. Fluorine 18, which is the FDG, it has it's not stable actually. When this fluorine is not stable, it will change the proton into neutron and produce the positive electron. Actually, in subatomic particle, there is a electron and also a positive electron. We know electron is negative, right? But this one is a positive electron. It's two different things. They have a different charge. So when they interact, they will produce positron emission. They will produce a two photon in opposite direction. So when they produce a two photon in opposite direction, this detector will detect the interaction simultaneously. So that's how the image is detected. Okay. And then why it is called as FDG? Because FDG actually is a fluorodeoxyglucose. FDG is a glucose. F18 is fluorine 18, which is radioactive. So the glucose will be tagged with the radioactive. We know that cancer, their food is actually glucose. So they consume lots of glucose. When they consume the glucose, simultaneously, it will bring the radioactive to the cancer location. So that's how we detect the cancer, where is the cancer is located. Okay, now glucose will localize to organ tissue that have cancer aggressively taking glucose to grow. And then we move to the next slide. Okay, this is the PET scan images after we do the scan. So this is what we have. So we can see the image in 3D. Okay. So as we can see, this is the patient brain, and this is the patient heart. Why it is black here? Because there is lots of uptake here, which means because brain has a high physiological activity, so it takes lots of the glucose. Heart also use energy to pump the heart, so they use glucose. That's why glucose is concentrated on the region. This is the patient kidney. Much of the activities is happening on the kidney, and this is the patient bladder. Okay, so when we fuse with the CT scan, the image will be in coronal view. The image will be like this. As you can see on the screen, this is the brain, and this is the patient body. Okay, so it's in reddish color. It enhance the patient organ. Okay, in normal CT scan, we cannot see all of this. We only see the slice by slice patient image. Okay, we move to the next slide. Okay, this one is the difference between normal CT scan and PET scan. For example, this patient have a liver mets. Okay, this patient have a liver mets. When you see at the CT scan, you barely cannot see the tumor inside. But when you see the PET scan, it enhance the tumor in the patient liver, as you can see here. Okay, another example is this one. PET scan showing squamous cell metastatic to the lymph nodes in the neck of the patient. When we do a CT scan, it only shows you this image, which lump inside this patient neck. But we cannot see actually where is the location of the cancer. So in this image, this one, it helps for the oncologist to contour this region for the patient to do radiotherapy later. Another example is small liver mets. Okay, this one, same as this. So the liver mets barely can see in the CT scan, but we can see clearly in the PET scan. Okay, next we move to the next slide. So how do FDG F18 produce? As I mentioned before, FDG is the medication which used in the PET scan. So it needs a machine which called cyclotron. So we see this one. Okay, this is the cyclotron. Okay, this is the machine, and cyclotron produce the fluorine 18 and transfer to production room. Firstly, they produce from here. Okay, they will insert the vial here, and they will bombard the target of the oxygen 18 with they bombard with neutron, and then they will produce the oxygen 18 will produce to fluorine 18, and then fluorine 18 is very unstable. So this fluorine 18 will be used in PET scan later. After they send the fluorine 18 to the production room, the final product will be produced inside this production room, which is they will take the fluorine 18 with the FDG, which is the glucose. Okay, after they produce, this is the vial which contains the FDG. They will transfer this vial to the hospital, which hospital need this medication. Okay, so usually we will receive like 10 ml of this vial, which contains 200 millicurie. Millicurie is a unit for the activity or the radioactivity, and it is calibrated in 10 ml. Okay, next, we move on to the next slide. Okay, this is example of patient weight. Okay, we have one patient. So we will produce 200 MCI for 10 to 11 patients, which means in one day, for a PET scan cases, we can do the scan for 10 patients. So 200 MCIs is enough for 10 to 11 patients. So one patient will allocate 20 MCI, approximately less than 10 MCI, because we have to consider the decay of the fluorine 18. Fluorine 18 is radioactive, so it has a half-life, which means the activity will reduce with time. So we usually use this references formula here. So we will prescribe 0.1 millicurie per kilo, which means when there is a 50 kilo patient, we will give them 5 millicurie to 6 millicurie. When the patient weight is 70 kilo, we will give them 7 millicurie and 8 millicurie. When the patient is 100 kilo, they will get more than 10 MCI. So I have a question here. When the patient weight is 38 kilo, how much will be dose given to the patient? Is it 3.8 MCI or or 5 MCI. So later you can answer at the chat box. Okay. And then we move to the next slide. So instead of using fluorine 18, we have another one modalities which uses as the same function as FDG. This is called as gallium 68, but there is a limitation on this. So we move on to the next slide. What is gallium 68? Okay, gallium 68 is a radioactive material which has same radioactive characteristic with fluorine 18, which is used for the PET scan, but it has a shorter half-life. It's only have a around 67.6 minutes. Okay, this gallium 68 has a difference in production. Gallium 68 only produced in a generator, in a small generator, where the FDG produced in a big generator, which is cyclotron. So we move to the next slide. This is how the gallium 68 produced. Okay, so what we need is a gallium generator, labeling, and also dispensing. So we can do this in the same area. We can do this in our own hospital, so no need to transport from other hospital. So any hospital in Malaysia, they can do this production within the hospital. They only need a generator, a synthesis module, and also a biosafety cabinet. This one is important for the protection for the staff because they handling with lots of radioactive material. So they have a specific thickness for this cabinet. Okay, so this generator produce gallium 68. This is synthesis module and cabinet. So we move on to the next slide. Why this generator is important? Since we already have the FDG, right? But why we need this generator? So this generator actually improve in diagnose patient with prostate and also neuroendocrine tumor. In normal FDG, they still can image the patient cancer, but it is not good as this gallium 68 lah for detecting the prostate and also neuroendocrine tumor. So this generator is easy to use. It has a small dimension and it can produce only for 3 patients per day. For PET scan, they can produce more than 10 patients. For cyclotron, I mean a cyclotron, they can produce more than 10 patients. But this generator only 3 patients. So that's one of the limitation. But after 3 hours, we can do the elution again, which means we can increase the number of patients by making the elution for the next production. Okay, so we move on to the next slide. This is the difference between cyclotron and also gallium 68 generator. Yes, we know cyclotron is very big compared to gallium 68. So the cost will be much more lah, kan? It costs 10 million per purchase. Okay, this one for mini cyclotron. For bigger cyclotron, which can produce more than 10 patients per day, which is they can produce any dose that they want, the cost is around 50 million, one-time purchase. Mini cyclotron, they only can produce 3 patients, roughly 3 patients per day. Next, the gallium generator, it costs only 200,000 per generator, but it can only produce for 3 patients and only specific disease, which is prostate and also the neuroendocrine tumor. Okay, so next, the difference product produced in fluorine 18 will be used as PET scan medication. Okay, the generator, which is GE68, it will produce the dotatate and also PSMA mainly because they have a specific synthesis module for this one. So Next, the difference is the image is more general for PET scan. Generated, the image is specific to neuroendocrine and also prostate, as I mentioned before. And for cyclotron, the limitation is we have to order from the factory and then they will send to our hospital. But when we have the generator for gallium-68, they only produce inside the hospital. So the advantage of this one lah. Okay, so cyclotron require major renovation, while the generator does not require a major renovation. They only need a few things, as I show you before. Okay, next we see this next slide. What is neuroendocrine tumor and prostate cancer? Okay, neuroendocrine cell is mainly found in small intestine, pancreas, and lung bronchioles. The cells act as nerve cell which receive messages from nerve cell and release some hormone. So neuroendocrine usually originate from pancreas, lung, and intestine. This is a rare disease, I can say. So the cancer begins in any of the cell and it grows at different rates and spread quickly, mainly from lung, pancreas, and also small intestine. For cancer patient, this one is, we rarely see this case in Malaysia, I can say, because mostly in Malaysia, we see a breast cancer. For male is a prostate cancer, NPC, NPC, and also usually intestine and cervix. Okay, so let's move to the next slide. So the difference between FDG and also gallium-68. For FDG, for this one, example of this case, 48-year-old man with SDHD germline mutation and multiple pharyngioma. When they do the PET scan using FDG, they can see only few dots of the patient cancer uptake. But when they use gallium-68, they can see it clearly, as you can see on the screen. This one is, you can see here, it's very, the tumor and also the cancer is already spread to the patient body. They use a gallium-68 dotatate here. And the left side, they use FDG. So, sorry. So this one, you can compare by yourself, this image. You barely can see the patient tumor here, but you can see it clearly on the right side. Okay, this is a case 2 lah, for patient mid-age with long-standing large neck carotid body tumor, newly diagnosed with metastatic. So let's move to the next. Prostate cancer. This one is mainly male, which is 50 years old above. Prostate cancer is uncontrolled malignant growth of cell in prostate gland, which affect all men around the world. Mostly develop from the gland cells that make prostate fluid that added to the semen. So this is a patient anatomy. This is the patient prostate. Usually there is a cancer cell developed from the prostate, and then when the cancer is malignant, they can spread to all of the patient body. So this one, there is what we afraid lah. Okay, so next study, I show you this one, a patient A and also a patient B. So studies on patient who diagnosed with prostate cancer. It shows PSMA positive lesion. When they use gallium-68, they can see the nodular pelvic wall. There is an uptake here, which means there is a cancer here. But when they use FDG, there is no cancer detected. Actually, there is a few cancer detected, but we barely can see the cancer here lah. So this one is the main advantage for gallium-68. And then the next example is a patient B. It shows clearly pathological tracer uptake on small lymph node of the patient. When we use gallium-68, the disease or the cancer is clearly can see here, but you barely cannot see when using the FDG. So let's move on to the next example. A study on a patient who diagnosed with prostate cancer. This is a patient primarily from prostate, and the cancer already spread to their body. And we can see the liver mets, there is a lesion in the liver here, but when you use FDG, we only can see the physiological uptake of the liver, but we cannot see specifically the liver mets. So this one can only produced by the gallium-68. That's the advantage of gallium-68. For lymph node uptake, patient B, there is uptake here, and there is no uptake here. Okay, so we move to the next slide. Cancer statistic in Malaysia, we use this. I found this statistic from the Malaysia National Cancer Registry report from 2012 and 16. The latest one, they're still not updated, but I think they already updated lah. Later, I will check back again. Okay, so the percentage of number cancer cases among men in Malaysia. As you can see, the prostate cancer is 7.7%, which is the third largest cancer. The highest cancer in Malaysia actually comes from the colorectal. So colorectal cancer mainly from our stomach, because I think usually due to the food lah. Usually our Malaysian like to eat snacks, like to eat food which is not really not contain I can say not good lah kan. Which contains high in free radical and so on. And the second highest is lung. This is maybe due to smoking. People who smoking is contributed more on their lung cancer. And then the NPC, this is like like Lee Chong Wei. He was diagnosed with NPC. Usually it's more on genetic lah. Usually Chinese patient gets the NPC more compared to other race. And then the other thing is lymphoma, skin, leukemia, and bladder. This one is the other cases is less contribute to cancer. And then in Singapore, we see the statistic. The main contribute to cancer also colorectal. So the second one is lung and also prostate. So we can see prostate cancer is one of the highest. Okay, so that's why we need the gallium-68 to have in all of our hospital. And then we move on to the next slide. So as a conclusion, PET scan is important in Malaysia since cancer cases rises significantly every year. And then we need both cyclotron and gallium generator in Malaysia to produce both medication, which is FDG fluorine 18 and also gallium-68. And then PET scan is important because they will improve the radiotherapy treatment for the patient. Usually, patient which is diagnosed with cancer, they are not know that they have a cancer tau. So this PET scan is a good baseline for the oncologist to see whether the patient have a cancer or not. And then PET scan, okay, this one I already mentioned. It helps oncologists to determine what are the next steps to treat the patient. FDG also important in detecting general type of cancer. And then gallium-68 specifically important to diagnose the patient prostate and also neuroendocrine tumor. Okay, so we move to my reference. Okay, end of the first slide. The next one is about the quality assurance in PET scan. So this one may be quite boring, but I have to share to you. This one is important for the physicists later. So in PET scan, we need to have the quality assurance. Imagine you have the machines, but you don't have the quality assurance. If you don't have the quality assurance, then the machine may get will have problem. Okay, because there is no checking. So quality assurance is like a checking. So we move to the QA part. Firstly, we refer to this technical quality control protocol handbook. This one already prepared by KKM. So we can get this copy from Radia MOH. You can search in the Google. So for QC, usually we have to check the machine daily, quarterly, and annual. Usually I will do the daily QC and also a quarterly QC. Annual QC will be done by a third party, usually Class H. There will be a company which do the testing for us. And then the first quality assurance I have to do for the PET scan is physical inspection. It's same as how we care our computer and also our machines. We have to check if there is any crack and defect, and also the data storage. Data storage have to be less than 60% of usage. And then the PET scan machine, we have to check for any defect or cracks. And then air conditioning. For PET scan, they need to have a specific temperature for the scanner, because when the room is too hot, there will be a problem to the PET scan later on. So the first thing that I will do is tube warm up. Like computer, like car, when we start our car, we have to warm up the engine, right? So same as this PET scan, we have to do a tube warm up. The purpose is to warm up the tube before perform a real scan. And then after we warm up, we will do the fast calibration. Fast calibration is require so that the KV and also MS setting within specific range. So if you, I think most of you are from the physics, School of Physics, so you will know this unit, right? So this one is a kilovolt, and also this is for the current milliampere. Okay, so to maintain the specific range, we have to do this testing. And next, we will do the this one is a daily CT bar phantom test. Why we doing this is actually to see the image that we produce within the acceptable unit. Okay, firstly, what I did is actually center the phantom. So after we center the phantom inside, we will position the phantom, and then we will align the phantom with laser marker, and then check the phantom centering. Phantom centering have to check like X and Y axis. Okay. And then we move to the next, which is scanning protocol. For scanning protocol, this one, we select the resolution in noise and also slice thickness. So we will do testing for the resolution and slice thickness. Okay. And then this is the interface. I just show you the interface lah. Okay. And then this is the result. This is what image that we get after we scan the phantom just now. The phantom is shaped like this. Okay, this is the phantom. And then when we do this, when we scan the phantom, we will get this image. So as you can see here, this is the water and this is the tissues. This one actually mimics the patient tissues lah, we can say. So what I did actually, I will put the ROI to the plastic, and also I will put the ROI to the patient to the water, and then we will see the mean value. So the mean actually will be shown on the screen. Okay, like this one, the mean is 129.87, and then here is 1.42. And then the next one is same as just now. We will measure the bar phantom here. This one actually, all of this is to ensure the image within the tolerance. Okay. The second analysis is to measure the standard deviation. So we will calculate the standard deviation for this patient. Oh, sorry, for this phantom. Okay, after that, we move on to the slice thickness. So we will test the phantom at different slice. Firstly at 5 mm, and then we move to 2.5 mm and also 1.25 mm. So different slice thickness, we have to change the window setting to different window setting. Like this one, we use window 100 and also level 50. Okay, so window and so the window will be shows like this, and then for window 100 negative 21 will be shown like this, and this one is 100 and negative 100. So as you can see in this bar phantom, we use a slice thickness which is 5 mm, right? So how do I interpret is by calculating these numbers of bar. So this one is 5 mm, so you have to calculate like this one, 1, 2, 3, 4. So which means the one that is visible is 4, and also this one is barely can see, so 4.5. So it's almost 5 mm. So the image is within a tolerance. Like this one, 2.5 mm. So when you calculate this bar phantom, it shows 1, 2.5. So it's 2.5 mm. So it is within the tolerance. Okay. And then this one also same. So let's move to the next. This one is this one is calculation for the mean. Okay, so I will put a different ROI for this phantom. I will put 5 ROI. Firstly at center, and then the rest is at the edge. So we will calculate the mean at the edges and also at the center. So we will compare the value. So in this case, I measure the mean at the center. The mean is 1.8, and then the edge mean is 1.94. So the value is not really is not significant, and then the uniformity is 0.14. So it is within the tolerance, which means our machine is within the tolerance. Okay, so I then conclude the test by jot down the value to this parameter. Okay, just now. So the result is this one. So the uniformity is within the tolerance. Now the last QC for this one is well counter correction. Well counter correction is to transform detected count rate, which is CPS, count per second, to radioactive concentration. This one to determine whether how well the detector count same to the radioactive concentration. Okay. So first of all, what I did is I used the other phantom. So this one is a NEMA Phantom NU2 1994 Phantom. So I will first fill the phantom in a distilled water. So I have a video here. So we will fill the phantom with water. Okay, next, I will position the phantom to the head scan. Okay, after I position the phantom, sorry, and then I will prepare the FDG. Just now I talk about FDG, right? So usually I will use a small amount of the FDG after the patient on that day finish. Usually they will have a left like 10 MCI lah. Okay, so I will do this dispensing. So we have an automated dispenser, which means we do not have to use our hand to to draw the medication. Okay, everything is automated. So this is the machines. It will draw the medication, and then it will take the medication inside the syringe. Okay, so the syringe is here. So I will take this syringe and put inside the dose calibrator. Okay, after I put inside the dose calibrator, there will be a reading on the calibrator lah, how much dose that we get. Okay, for the next slide, I will, okay, this one is the this one is a dose calibrator. After I measure the how much we get the medication inside the syringe, I will inject the FDG to the phantom. Okay, and then I will position the phantom back to the PET scan. Okay, and then this one for analysis. For analysis, we will put the pre-injection activity and also post-injection activity, which means previously I inject this phantom, right? So there will be a residue inside this range. So we will measure the residue, okay, and then we have to put inside the system. After that, we will select the well counter correction protocol, and then we select the scanning range. After that, we wait for the scanning. Usually it takes 30 minutes only. And then after that, the result will be shown like this. So in this case, sensitivity and activity factor are within range. It is 2.6, okay? Sorry, this one I mistakenly put 2.02. Okay, so no need for the action. So it is within the tolerance, which means our machine is in a good condition. Okay, so finish for the quality assurance. So that's all for me for tonight. Thank you and have a good day. Anything you can ask me in the chat. Also, you can just ask question directly. Sure, no problem. Or anything, if you're shy to ask me a question, you can email me through this email. Okay, thank you very much.
Okay, thank you so much, Fahrizuan. You have explained very detailed. So I remember, like during my class, you're always the one who presented at the front. Okay, any question? I have actually one question personally sent to my chat box. So may I know how do gadolinium-68 dotatate differs to lutetium-177 dotatate in neuroendocrine tumor?
Okay.
Ingat ke?
Okay, sure. Dengar. Okay. Okay. For gallium-68 dotatate, lutetium 177 is theranostic. Sorry, I mean it is a therapy. Usually, theranostic is a diagnostic and also a therapy, which is combined. So usually in the scanning of the gallium-68, usually doctor will diagnose the patient, see the patient location first. I mean the cancer location for the patient. After that, for lutetium-177, they have to do another appointment for the, I think they have to do another appointment to do the therapy for the patient. So they will do the injection. They will give the patient the lutetium-177. They will inject the patient, and then the lutetium will targeted to the patient cancer cell. Yes, that's what I know lah for lutetium-177. Yeah.
Okay, there is more at the chat box. So what is the limitation of the PET-CT scan if compared to CT scan?
Okay. The limitation for PET CT scan compared to CT scan. Okay, CT scan does not have a medication, which is FDG. We can patient do not have to prepare for fasting, something like that. Patient can come to our hospital and then they can scan directly uh, on that day. But for PET scan, they have to do appointment and then they have to wait for the medication to arrive, and then they will surely have to pay more lah for the scan because the cost is much more expensive compared to CT scan. And patient have to fasting for 6 hours. For CT scan, usually patient don't have to fasting because PET scan, when patient do not fast, when patient do not fasting, the glucose that they take right, they eat right. So the glucose will move to the cancer cell. So which means it's already uh, combined with the FDG. So there is problem uh, in image diagnose. Yes.
Okay, next question. There's actually a lot of questions. Wait,
Sure, no
So
problem.
can F18 tag with other than glucose?
Okay, sure. Yes. F18 can be tagged with PSMA. Also, they can tag with the neuroendocrine tumor. Just now I said dotatate. So other than that, usually in Malaysia they tag with FDG lah, glucose, because it is really useful in detecting the cancer location. Yeah.
Okay, there is another question. So during your undergraduate study, what is the most important subject that need to be stressed on as you are working as a medical physicist now?
Okay. Commonly diagnosed.
During your undergraduate study, so what is the most
Okay,
important subject that you think are needed to be stressed on? That could be important to
important.
that.
Oh, okay.
Yeah, to work as a
Actually, the
medical
most
physicist.
important is I can say each subject is important actually, but the most important is I think I uh, mostly use is dosimetry lah. Dosimetry, because in some cases when we need to solve something like a calculation, right? Usually when our machine down, let's say our dose calibrator is down, so how do we calculate the dose that is needed to prescribe to the patient? So we need to use a manual calculation for that. Yeah. So dosimetry and also knowledge in clinical diagnostic imaging is important. And then for radiation knowledge it is the fundamental, which is really need as a physicist. Because when we don't have the knowledge in fundamental, then how do we solve the problem, right? Yeah. How do we how to say how do we interpret something lah, if we have if we face a situation like to do the calculation or something. Yeah.
Okay. So based on your previous slide regarding the statistic on cancer in Malaysia, so why does more Chinese patients suffer nasopharyngeal cancer?
Okay, from my study, from my reading, usually why actually because usually their grandfather from China, right? Usually they eat lots of how they eat ikan masin lah. Usually they eat lots of MSG, which is very high in salt. So from that one, it might be the reason why they suffer from that one. So it's genetically from their nenek moyang lah, kan, we can say. And then it will goes turun temurun to uh,
So
their
you would say
family.
that it's actually a genetic
Yes, I can say
issues
from
lah.
genetic. Yeah,
Okay,
from my reading lah.
okay. So another one, can I ask what kind of cancer commonly diagnosed by PET CT other than NET and prostate?
Okay,
And
the
how the
most
patient is classified, whether they need a SPECT CT or a PET CT. Do
okay.
you have SPECT CT as well there, or you just have PET
In
CT?
KPJ, we only have a PET CT. Okay. Actually, SPEC CT usually used for mainly uh, it's same as PET actually to detect a cancer when there is a location, but the image is more clear and more specific compared to SPEC lah. Mostly the disease mostly the patient who come for the PET scan, right? Usually patient who diagnosed with uh, breast cancer, cervix, and also lung cancer primarily, and also nasopharyngeal cancer. Yeah, this one the most. And also for the difference, how do we difference between PET and SPEC? SPEC usually use to see the bone cancer lah, usually for bone scan. For PET scan, it's general. You still can see the bone, but uh, I think it's not specifically on bone also. It's also in the tissue level. Yeah.
So what is the parameters to calculate for each patient for radiation protection purpose in your hospital? And
Uh,
equivalent dose or effective dose or absorbed dose?
okay. Which question? Sorry.
From the Coxinian.
Okay. Parameter to calculate for each patient for radiation protection purpose for your equivalent dose or effective absorbed dose. Okay. So usually for patient for radiation protection purpose in hospital, we will use for patient. Okay. Protection. Usually it is we know that effective dose is quite hard to calculate because they have to times with the specific organ, right? So usually we will use a absorb dose lah, as a general, as a one whole body for the patient. Yeah. So when we prescribe the patient with 6 MCI, usually we will measure based on the how much they get. Usually we can measure the patient from 1 meter and also at their surface using a surveymeter, so we can see how many Roentgen or millisievert that they receive at that time. But the dose is actually reduces with time because they have a half-life, right? FDG, they have a half-life of 2 hours. So in a time, the dose will be reduced. Yeah.
So the second question, so what is the role for the medical physicist if the activity of radiopharmaceutical, which is the FDG obtained, is less than the activity needed for the diagnostic imaging?
Okay. So actually it happens few times when the radiopharmacists draw the dose and then they mystically change the patient, which is patient less weight compared to the patient that they have to inject. So in that case, we will calculate how much MCI that the patient lacks, and then we will draw and add another dose to the patient, and then we will calculate the whole thing back again lah. So after we add, we have to calculate using we have a formula to calculate the final activity equal to initial activity times with the exponent to negative lambda t, which means they have to calculate the current activity for the patient first. Yeah.
Fahrizuan, so normally the one that would do the calculation, is it the pharmacist or the physicist?
Usually, I will do the calculation. Yeah, physicists will do the calculation. Yeah.
Okay. So is FDG can cure patients as well?
FDG cannot cure patient. They only can diagnose patient because FDG is only a very low radiation which used to image the patient image the patient cancer lah. Which location depends the cancer already spread to the patient. Yeah.
Okay,
But
so there is
in gallium 68, in gallium 68 lutetium 177, yes, it can cure. That one is a theranostic, which is diagnostic combined with therapy. That one, I think in Sunway already started for this therapy lah. Yes.
okay. So just wondering, in KPJ Johor, how do you normally calculate those? So simply, I'm not so sure, is that a mind skin calculation or do you use
MIRD scan
any
calculation or
sort?
do you use any sort of software example or Linda? Okay. Okay, in KPJ, okay, we usually firstly based on patient weight. So how do we prescribe? We based on 0.1 MCI times with patient weight. Like when the patient weight is 50 kilo, we times with 0.1 MCI, then we will prescribe 5 MCI. So in this question, how do you normally calculate those? Okay. I actually heard about MIRD scheme, and actually we are not using this one lah for those calculation. Yeah. Software Olinda also so far we are not using this software lah to calculate the dose. Yeah. I think this one maybe because KPJ is still a small center lah, I can say. In terms of facility for physics, like software to calculate all those things, they still have lack of that one lah. Yeah.
So is it possible to clarify the mechanism of the work of PET scan in short?
Also clarify the mechanism of the work of PET scan, which means to clarify.
Maybe how it works, how do you get the image, probably,
Oh, okay.
the question.
Okay, so firstly we will receive the FDG, right? And then we will inject the FDG to the patient, and then patient will be lies for 40 minutes. Why they have to lies for 40 minutes? Because we need to make sure the patient body uptake the FDG well, which means the FDG already gets to the patient location. I mean the patient cancer lah, can. And then after 40 minutes, then we will do the scan. Usually we will use 2 minutes per bed. So they will do the scanning for 15 to 20 minutes around that. Yes. So after that, the image will be, we will get the image in CT and also PET. We will combine the image and we will send to the doctor computer. So the doctor will translate the image later.
Who perform annual QC on your PET scanner?
Annual QC usually are consultant physicists. They have to do the annual QC. In Malaysia, they have a regulation which we need to hire the Class H, which is a company which include a QC assessor and also a consultant physicist to do the annual QA. So annual QA, they have lots of testing they need to do. For example, NEMA test, image quality test, and all those things. Yeah.
So basically, you have to sub it to someone else lah.
Yes.
So
We
the
have to,
physicist involved can in-house can't really do it.
In-house, yes, can. Actually, in IKN, they have the authority or they have the they can do the annual but they need to have a written letter to BKRP lah, bahagian kawal sedia.
So basically, this one is under regulation.
Under regulation, yes.
I see. Okay.
Sakina?
Yes.
I have one question.
Okay, but Azra.
Sure.
Yes.
Okay, Mr. Fahrizuan, thank you very
Yeah.
much for your sharing. tonight.
Okay.
Okay, I would like to ask about the procedure before scanning. Is there any difference between F18 and germanium 18 for the procedure before scanning? Like, if I'm not mistaken, for F18, you have to wait for a while before the scanning. How about the germanium 18? And the second question is how long the scan takes. Yeah,
Okay.
thank you very much.
Okay, sure. Okay. So for the questions, actually the half-life is different. For gallium-68, it's around 60 minutes, which is 1 hour. Fluorine-18 is 2 hours. So for the gallium-68, it takes a shorter time lah for the patient need to wait compared to fluorine-18. And then like fluorine-18, we actually still don't have this gallium-68, but for fluorine-18 is around 40 minutes to 1 hour to ensure the uptake is fully taken by the cancer cells. But for gallium-68, it should be less than that. Yeah. And then for the next is what is the next question? They have two questions, right? From
How long the scan usually takes?
scanning. Okay.
Is it depends on type of cancer, or
Okay.
it's same for all types of cancer?
Okay. Usually the scan is around 20 minutes. But for a whole body scan, which is palliative case, usually for cancer who has a malignancy, I mean, they already spread to other body, like their feet, their bone, right? So we will have to do the whole body scan, which needs more than usually 30 minutes. Yeah. So for a specific location, it takes around 20 to 15 minutes only. Yeah.
Oh, okay. All right. Thank you.
Okay, sure.
So next question, I used to heard about lutetium-177 dotatate or PSMA for prostate cancer therapy too. So does Malaysia use only gallium-68 or they also use other radionuclide?
Okay, yes. I heard about lutetium-177. In Malaysia, Sunway already started this treatment. It is theranostic, which is diagnostic together with therapy, which means they diagnose the patient first using gallium-68. After that, they do the therapy for the patient using lutetium-177. So they have a specific calculation for that one, for the dose to calculate for lutetium-177. How much that we need to give to the patient, they have the calculation for that one lah. But in our hospital, we still not start yet. So in terms of calculation, maybe later I can explain to
Maybe next session.
maybe next session. Yeah, because we still don't have these modalities lah in here. Yeah. And then does Malaysia use only GA68 or use other radionuclide? Actually, Malaysia use GA68 and FDG. This one is the general radio pharmaceutical that we use lah in Malaysia. Yeah.
So is there any symptom that will happen after injection of the FDG?
Okay, actually symptom, no, because it's only a low dose. Patient usually does not have a dizziness or something because it's only a low dose and it's not we does not give a higher dose like radiotherapy. Like radiotherapy, we give them more than mega electron volt. Like this one, it's only a few it's only a little lah dose that we give. So no side effect at all lah. Yeah.
So maybe he was asking also about allergies or something after the
Scan.
injection.
Usually allergy, some patient have the allergy, but it's not come from the FDG, but it's come from the contrast. Contrast media, which is the CT scan that injected to the patient. Since we have two, right? PET and
PET
also
plus
CT.
CT.
So the CT scan, sometimes doctor will give the patient with contrast to distinguish between patient blood vessel and also the tissues, so that patient sometimes they have allergic with the contrast media. Yeah.
So
So
they take in at the same time, like simultaneously after the injection, and then after that they have to take in the contrast.
Usually they have to do the injection first for the FDG. After that, we will the contrast only given during the scanning. Firstly, patient will be injected with the FDG in the room. After that, we transfer the patient to the scanning room, and then we will inject the patient with the contrast during the CT scan. Yeah. And then for protection, radiation protection, after patient finish the scan, a pregnant woman cannot sitting near to the patient, and also a baby 1 years old below, because baby and also pregnant woman, we afraid that the baby will get stochastic effect lah, which is a long-term effect, yeah, due to the radiation, because they still have uh, they're still growing, right? So we afraid that they get mutation lah. Yeah.
So can pregnant women actually undergo PET CT
Actually, we are
procedure?
pregnant woman cannot undergo PET CT unless we we can say that we compare the benefit with risk, which means when a patient get a cancer, which is very ill, and then patient have a suddenly patient discover that she is pregnant, and then it depends on the oncologist or the specialist whether we need to see the patient cancer or not. So when we need to do that, then we have to proceed. But usually doctor will not suggest to do that. Yeah, because it will affect the patient baby inside. Yeah.
So what is the important criteria for fresh graduates? So since they are not inexperienced with any types of modalities, because we have fresh grade, right?
Fresh grad,
Maybe
yes.
any advice or whatever you want to
Advice.
say?
Okay. Okay, I think you have to read journal a lot to enhance your knowledge first, and then you can, during interview, you have to be confident, and also you need to know more on clinical side, because I understand during my studies, I think clinical exposure is very little. So we have to share, and also we have to talk with people who is experienced and exchange knowledge with them. Yeah. So the most important thing is reading lah. So you have to read a lot, the new topic, and also the current topic of radiation lah, regarding radiations mostly. And another criteria is first one is reading, and then
Maybe in terms of
score.
your
Yeah,
personality as well. How would you actually present yourself in front of the interviewers?
yes,
Because
correct.
because they are already, I would say that graduated, because they're just now just waiting for the final mark.
Oh, I see.
Yeah, for
Yeah,
project.
project. I
And
think
after that will be done, yeah.
yeah, I think they can start learn how to do the resume maybe, and also try to try to improve their skills to talk with people. Yeah, that's the most important.
Do you ever encounter any contamination or incidents
Incidents.
regarding the radioactive sources? So
Okay,
if
yes.
yes, so what is the action taken?
Okay, usually I give this situation. Okay, when the patient suddenly vomit, so what actually we have to do? Okay, their body contain a radioactive material. So when they vomit, their vomit actually contains a radioactive, right? So first, as a physicist, we have to measure the contamination first, how much the reading, and also we have to record the reading. Usually, from my experience, the reading is not much lah. I can say it's negligible, very little. So For the contamination process, we will we not have to seal the area because it's only a minor spillage. We have two, which is major and minor spillage. Minor spillage is like contamination, something like that. So we will wipe the vomit. We will wipe the patient vomit, and then we will put to a plastic bag, which is specialized plastic bag. Usually it's a yellow color, and then we will put to the decay room lah, to make sure it is safe. After that, the next day, then it can be put to the general waste. Yes, that's all.
There is actually another question. I think this is also commonly asked, that's sent personally to me. So because you are dealing with the radionuclides, right? So
Yeah.
why you didn't wear any protective? Maybe
Okay.
why you didn't wear a leg gowns and you
Leg gown.
actually handling all the
Okay.
procedures?
Okay. In diagnostic imaging, we usually wear a lead gown, right? Because the radiation is very little compared to PET scan. Radiation is not much as PET scan. So the lead count is actually less than one. I think it's around 3 mm or less than 3 mm thick, if I'm not mistaken. So for PET scan, the energy is high. They produce an inhalation which is 511 keV, and then it require a high Z number material. So for 6 MCI, imagine for 6 MCI, we need to use 9 mm shielding. 9 mm is very thick. So we cannot wear a 9 mm lead gown. They still not produced because we cannot carry the 9 mm thick of a lead gown. They are not producing that. So if we wear a lead gown which is less than 9 millimeter thick of the lead, then it will produce a Bremsstrahlung lung effect, which will further reduce a secondary radiation to our body, which means when we wear the lead and then the radiation bombard our lead gown, it will produce another secondary radiation, which is pointed to our body. So in order to attenuate the radiation, we need to weigh at least more than 9 millimeter lead. We can use other material, which is tungsten. Tungsten have a high Z number. It's only sorry, it's 5 millimeter lead equivalent to 9 millimeter, which means when we have a 9 millimeter lead, we need to have only 5 millimeter tungsten, which means a little thinner lah compared to lead. But tungsten is very expensive. Still not practical to be used in PET scan lah, because we cannot wear a very
You'll
thick.
be very heavy as well, and then you have
Yeah,
to wear
very
it.
heavy.
Yeah. So
Correct.
okay. And the last question over here, can you brief about your education, also work journey? Yeah.
Education work journey. Okay. Okay. Firstly, last time I'm studying in Kelantan, USM, in USM Kelantan, in medical radiation. 4 years after that, I further my study in master. 1 year in medical physics coursework in Penang. That's how I met Dr. Sakina there. And then after that, 3 months after that, I get the offer from Gleneagles Hospital in radiotherapy department. After 1 year working, I resign, and also I get another offer from KPJ Johor. Yeah. So in radiotherapy, I have experience around 1 year lah, I can say. In here, I mostly 2 years lah. Yeah.
Which one would you actually enjoy most working? Is it actually in the radiotherapy or your current
Actually, both actually.
position?
Because now in diagnostic imaging, I only cover for PET scan, right? So I think I cannot learn much of the radiotherapy lah right now, because now they have their own physicists, and diagnostic imaging, they have their own physicists. So sometimes I only can see and also learn what they do, the planning during free time. Yeah. So I enjoy working both. In
So,
radiotherapy, we have to do a treatment plan. In nuclear medicine or diagnostic imaging, we more on radiation protection. Yeah.
so basically, your current how would I say scope of working now is mainly on the PET CT lah. So
Yes,
not
correct.
not in the other
Yeah. But
okay.
sometimes I'm not officially do a treatment plan, but I usually join them to see the case. Yeah. But usually the physicists will do the planning.
Okay. All right. Thank you so much, Fahrizuan.
Yeah,
Glad
sure.
to see you again.
Sure. Welcome.
Okay. We are going to have a photo session. Since now it's already 9:41. Can you turn on your videos? So I'll wait maybe for a few minutes before we have our photo session. We have many of the alumni also joining us today. So maybe next time we can have a second session together.
Sure, maybe. Later, yeah. No problem. We can arrange for that. So lastly, I think thank you for joining, and thank you for Dr. Sekina for giving me a chance to do this sharing session.
Thank you for
I'm
accepting
sorry
the
if
offer.
I
I know you are
am
very
not
busy as well.
a bit yeah. So I think I'm sorry if I not really answer your question, but if you have any question, further question, you can email to me lah. Yeah,
You did very well. I believe that you explained it very well
hopefully.
and in details as well and in simpler ways. So I believe a student will understand.
Yeah, because I afraid to put much of the text because maybe the presentation will be quite boring, right? So I put pictures now, more on pictures. Yeah.
Anyone else coming to take the photos? Let me see. Second. Let's come. Okay. We'll take now. All right. Okay. 1, 2, 3. Wait. Sorry. Sorry. One more time. 1, 2, 3. Face this one first. Okay, one more time. 1, 2, 3. All right. Okay, thank you so much, Fahrizuan. So maybe I
Sure.
will invite you again for the second session.
Okay, we can arrange for that.
And perhaps is if we can have like a virtual tour to your hospital as well. So I've been thinking
Oh,
because
okay.
now because of the pandemic, so students can't really go
Yes,
to the hospital.
yes,
So
I
perhaps we
understand.
can have a virtual tour see you at your hospital.
Okay, sure, no
Okay, thank you
problem.
so much.
Okay,
Thank you for the participants as well. See you again, inshallah, for the next program. Bye,
okay,
everyone.
okay, thank you.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Congratulations, Fahrizuan.
Bye.
Congratulations.
Thank you.
Thank you, Mr. Fahrizuan.
Okay, welcome.
Thank you.
Okay, welcome. Thank you.